All right, next up, it's my pleasure to introduce Dr. Michael Reardon. Mike is a professor of cardiothoracic surgery here at Methodist. He's the leader of multiple national trials in TAVR and other structural devices, so we're lucky to have him with us this morning and also lucky to have him at our institution running these programs. Thank you.
Well, Steve, thank you very much. It's going to be hard to follow behind Vera. That was a great talk. My subject was which TAVR valve is best for which patient. And it's kind of interesting because I do have a lot of conflicts with different valves. I've had the opportunity to be the PI in a number of the trials out there. I sit on the executive committee of pretty much every trial except for the partner trial. They're all my good friends. I don't know why I've never been part of the partner trial. But we use all the valves, including the Edwards valves. But I don't think I'm going to let it influence what I'm going to tell you, other than the fact that when you start talking about which valve is best, it becomes difficult for somebody that uses all the valves. I'm a father. I have 2 daughters and 3 granddaughters. It's like coming into a public space and somebody says, which one do you like the best? There is no answer that I can give that will not get a daughter, a granddaughter, or Grandma Bunny mad at me. So I will be a little circumspect in some of the things that I'm going to say. Now, when you think about valves and you're thinking about which valve to use, it's important to understand the concepts behind the valves. Because as Colin showed you with the mitral valves, there's not quite as many aortic valves because the field's already becoming somewhat saturated, but there's a lot of different valves out there. All of them follow one of 3 general design concepts. There is a balloon expandable valve. Right now that is the SAPIEN 3. If you're in the US, outside the US, there's some other balloon expandable valves, but this is the only one we have in the US. And right now it's cobalt chromium with a little skirt around it. There is a self-expanding valve, which is nitinol with a porcine rather than a bovine leaflets in it. Now, there's also other self-expanding valves. I show this only as the primary example. This is one that is approved now, but the Portico valve just finished its trial not too long ago. In about a year, we're going to have data on that. It's a little bit different. It's intraannular rather than supraannular, but again, it's the same concept. It's a self-expanding valve. And then there's the mechanically expandable valve, which is the Boston Scientific Lotus valve, which is interesting because it too is nitinol, one long piece of nitinol that you let out to its normal size, and it has a buckle and a post with a wire. As you turn a handle, you shorten it, and as you shorten it, what happens? It widens out. And they each have unique things. The Lotus was the first one that had a sealing skirt on it. Sapien followed behind that, and now Evolut has come up with Evolut Pro. They all have versions of sealing skirts. And those will have different effects depending on the different anatomy of the patients. Now, Vera showed you a little bit of this. This is the high-risk trial for partner on the top, no difference. This is the 3-year data for the core valve on the bottom. Year number 1, there was actually a statistically superior survival for TAVR over surgery. It's the first time we had ever seen that for a device over surgery. There is no other device that has ever shown that. And it was a little bit of question because when Dave Adams presented it, it was a one-tailed alpha because of the way the statistics were done. Everybody gets all freaked out because it was one tail. So at 2 years, I had the opportunity to present it at ACC, and with a 2-tailed alpha, it was still statistically superior. 3 years, Mike Deeb presented it. We lost the statistical superiority, but we still had a delta of 6.2% in favor of TAVR. Our numbers are just getting smaller. But again, this was pretty good data for the high-risk group. The 5-year data I'm going to be looking at over the next couple of weeks, and we're going to be presenting the 5-year data coming up very soon. We just finished the REPRISE 3 trial. REPRISE was the Lotus valve that we randomized against the core valve and the core valve Evolut when that became available. And what we found is there's really no difference in how these valves do from the standpoint of safety. Lotus is a little bit better for paravalvular leak because it was designed with a skirt for that, but these valves all tend to work pretty well. There's 2 intermediate trials that have been done. Vera told you about the PARTNER 2 trial. There's really no statistical difference in survival or primary endpoint. And the same thing for SURTAVI, no statistical difference in survival or endpoint. So we now have it all the way down to that. We have our guidelines where we have this 1A. We go into the US guidelines. Now, in the US guidelines, when I was going to present SURTAVI, these came out 3 days before the ACC. 3 days before the ACC. And we have a class 2A. I had a bunch of stuff I was going to say, Pat, but you guys really goofed me up when you put this out there. And to be class 1, you need 2 randomized trials. If you just waited a couple of weeks, because now with SURTAVI data, it's going to be a class 1 next time you guys meet. I know it is. And that leaves us with the low-risk trial that we're going to look at. And of course, there are 2. There's the Edwards trial that you talked about, and there's the Medtronic trial. Both these trials are basically done with their initial enrollment, and they're both continuing to enroll in what the FDA wants in the leaflet motion abnormality sub-study, which is what Vera talked about, although hers was really a thrombus. Which has been unique is when we discovered these things can have some thrombus on the leaflets and a motion abnormality without increasing the gradient. And Carlos Ruiz found that when he just decided to scan a patient once. And then that stopped the Portico trial for a while. Now the FDA requires this of all the trials. And that's a little harder to enroll because a lot of people put their surgical valves on Coumadin. If you have on Coumadin, you can't be part of the trial. And so we're having trouble in both trials filling that out, and the FDA won't let either of these trials be declared closed until such time. And so my plan is to present the low risk at ACC 2019. So I think we're going to have low risk data coming up in the very near future. Nobody knows the answer to this, but I, having been in this field a while, I strongly suspect they're both going to be non-inferior. Now, if you just trying to get an idea where we're heading, I actually looked at the survival for surgery in TAVR and all the trials that are out there, the randomized trials that have been out there. The top line is a linear regression for the surgical survival. The bottom line is a linear regression for the TAVR survival. And as you move into lower risk trials, what do you see? You're approaching a common point. Not a real big surprise. So one of the things as we think about which valve to use, and are we going to use a surgical valve or a TAVR valve, is if you really want to go to lower risk, you have to show equivalent or better mortality, hemodynamics, morbidity, quality of life, durability, and patient acceptance. So we'll start for a minute and look at CERTAVI, because that's the last intermediate trial that came out. CERTAVI was a randomized trial that included the US, Europe, and Canada. Now, the interesting thing about it is this was 84% first-generation core valve. Still a first generation. This is like partner 1A. Remember, partner 2 was the XT, second generation, and then there was a non-randomized S3. So this is mainly a first-generation trial. It's also interesting that it was 94% transfemoral. And remember, the early partner trials were 50% transapical, 50% transfemoral. This is where the field is going, 94% transfemoral. But then we also did a continued access, because when you finish, the FDA lets you do a continued access. And by this time, we had Evolut out there, and so now it's a 93% second-generation trial and almost 96% transfemoral. So what are the outcomes at 30 days that we can kind of look forward to the future and figure out where we're going to go? Well, if you looked at the all-cause mortality, this is actually one-year data from everybody reaching 1 year. And remember, CERTAVI was done with the Bayesian analysis. I could bore you with a long talk about Bayesian. I'm not going to. But we're going back when everybody reaches the full 1 and 2 year endpoints and doing standard frequency statistics on it to see how far off we are. And we were off by 0.1% from the Bayesian prediction. So for surgery, we had a 30-day all-cause mortality of 3.8%. For TAVR, it was 2.8% for all-cause mortality or disabling stroke. 1.6% for surgery was the mortality at 30 days. That's with an SDS of 4.5%. That gave you an observed to expected of 0.38. That's the best surgical results we've seen in any of the trials, and still TAVR stood toe-to-toe. TAVR a little higher, had an OD of 0.5, but again, we're getting really low. Remember partner 1A, there was twice the number of strokes for TAVR than surgery. Everybody was worried about that. Every randomized trial since then, TAVR's been as good as or better than surgery. And other complications still going down with time, but this is the continued access. All-cause mortality or disabling strokes in 275 consecutive patients over 79 years of age, 0.4%. Mortality, 0. 275 consecutive patients older than 79, 0 mortality. That gives you a feel for where we're going as we go to low risk. When we were planning the low-risk trials, Mike Mack, a good friend of mine, and a surgeon from Dallas, and Marty Leon, a cardiologist from New York, we're running Edwards. I'm running low-risk Medtronic with Jeff Popma. And we said this is going to be the 1% trial. 1% mortality, 1% stroke for surgery. If we can't be 1% with TAVR, we're in trouble. Well, I'm not a statistician, but 0 seems better than 1% to me. So it is amazing where we're going. Now, as we talk about these valves, there are some fundamental differences. The balloon expandable has had a lower pacemaker rate than this valve. But one of the things that we've found is that as we've gone to the newer generations, the pacemaker rate now has fallen down to 16%. For our self-expanding valves, our pacemaker rate, which I track, is about 13.5%. Now, if we want to go to lower risk, if you look at the meta-analysis of pacemakers in surgery, they're usually between 3 and 11%. The older you are, the higher the risk is. We really need to be less than 12%. If we really want to make this for people that are lower risk, less than 12%. Now, remember, the people in partner 2A and CERTAVI were basically 80 years old. They were intermediate risk, but old. These low-risk cases are still going to be in their mid-70s. We're used to looking at 60 years old and thinking they're low risk. They are low risk, but they're low risk in their kids compared to what we've done the TAVR trials on. So if you're 80 years old, a pacemaker may not matter to you. But if you're a robust 65-year-old guy like me, it may be a problem. So we need to get our pacemaker rates down, and they are coming down. Now, the one thing we've seen with these valves is the hemodynamics are just superb. They're always as good as or better than surgical valves. And this is the hemodynamics from core valve. Now, Edwards is an intraannular valve. It's a balloon expandable. It sits inside the annulus. Surtavi sits above the annulus, and Lotus sits in the annulus. The intraannular valves are never going to have the hemodynamics of the supraannular valves. In fact, the supraannular valves beat the surgery at every time point. And in fact, we have single-digit gradients. Now, those of us who have been operating all our life, we rarely come out of the OR with a single-digit gradient unless I do a root. It's almost unheard of. In fact, if I give you somebody that's 12 or 13 or even 14, you're pretty happy with me, which is kind of the intraannular valves. These are consistently single-digit gradients. I mean, we get DVIs of 0.75. I mean, unbelievably good DVIs. And this is the Lotus. Lotus, again, did not do quite as well as core valve. Not a surprise, it's intraannular. But again, all as good as or better than the surgical stented valves that we have. Now, the other thing that was interesting from Surtavi is we knew that the primary endpoint of all-cause mortality or disabling stroke was as good as surgery. We knew the mortality was as good as surgery at 2 years. But your patients want to know how they do at 30 days. Well, at 30 days, there was statistically less all-stroke for TAVR, statistically less transfusion for TAVR, statistically less acute kidney injury for TAVR, statistically less shock for TAVR, and statistically less atrial fibrillation. Now, why is that important? Well, in 30 days, you don't want those things. But AFib, transfusions, and kidney injuries, they not only kill you now, but they have a lasting effect. They kill you on into the future. In fact, as surgeons, if we want to compete, if we can't get rid of AFib and kidney injury and transfusions, we're never going to be adequately able to compete with these valves. Now, surgery still did better in some places. It always had less PVL and less major vascular complications, but the major vascular complications continue to go down. So where are we lacking? Well, we have the mortality, we have the hemodynamics, we have quality of life. I didn't show you this, but I think several people have showed you this, but the quality of life for TAVR and surgery both goes way up. It goes up by over 20 points, which is a large increase in your quality of life. TAVR just goes up faster. If you get a transfemoral TAVR, 1 month, you're back to normal. Surgery, it takes longer. By 6 months, everybody's the same. And I didn't say anything about patient acceptance because all the patients want a TAVR. I mean, people come to my office and they say, Doc, I've been on the internet, I want a TAVR. I have to say, but you've got an aortic aneurysm. You don't need a TAVR, but I want a TAVR. It sounds so good. Everybody wants a TAVR. So we're still left with two things, morbidity and durability. Now, morbidity is a little bit different between the valves. There's PVL and there's pacemakers. In the original Edwards trial, the pacemaker rate was no different between surgery and the balloon expandable valves. By the time we got to S3, it went up a little bit because of the skirt, and I think we were originally implanting them too low. It's starting to come down again as we learn to implant that valve better. For core valve, it's coming down more and more. It was too high to begin with. In the latest iteration of the Pro, which had the skirt on it, it was about 12.5%. That's a very small trial, but you can see where we're going. So this is the Evolute Pro. This is the one that has the skirt on it. Pacemaker rate's down at 11.7%. This is what's happening to permanent pacemakers over time. Centura is the new Edwards self-expanding valve, very low pacemaker rate, intraannular valve. Again, permanent pacemaker rates in every trial we do are decreasing, and PVL is decreasing. This is the Lotus you can see on the far right for 1 month, moderate to severe, 0.6%. Starting to look a little bit like a surgical valve. And this was the Evolute Pro. This is the latest self-expanding that has a skirt on it. You know, if you're going to younger patients, you don't want to have paravalvular leak. At 30 days, 3/4 were none to trace, 1/4 was mild. By 6 months, this continues to get better. Why? It's a nitinol valve. It continues to expand. Just like braces move your teeth, this moves the annulus and remodels it. And it was almost 90% none to trace and 12% mild. That looks a lot like surgical data. Surgeons will tell you there's never PVL, but the echo guys will tell you there's some. It doesn't go away. It's there. That looks like a surgical valve. And this is quality of life. By one month, TAVR is always doing better if it's transfemoral. By 6 months, they're all the same. Durability. Vera mentioned that the Edwards 3 trial is going to be a 10-year trial. Interesting enough, both the intermediate trials, which were designed as 5-year trials, we went back and lobbied the sponsors, and both those are going to be followed for 10 years now. So we're going to get good data there. And the Medtronic low risk, just like the Edwards trial, is designed as a 10-year trial. This is going to be the best data we have both for surgical valves and for TAVR valves to find out durability. So again, where do we stand on this? We've kind of answered all those questions, and here are the valves that we have that we can choose from. They're all going to be a little bit different. If you have a lot of calcium, you really have to worry with the balloon expandable about rupturing an annulus. We don't see that much anymore, but we saw it a fair amount when we first started. Whereas if you have a self-expanding valve, you have to worry about paravalvular leak. Well, the interesting thing is something like the Lotus you can put in there, and the Lotus can be expanded to its complete lock position, and you can look at it inside if you like it. If you like it, you can let it go. If you don't like it, you can unlock it and move it or put a new valve in. Whereas the core valve, you let it out to about 2/3, and then you decide, does it look good, and I let go and hope it ends in the right place. And the balloon expandable, once you blow it up, it is what it is. You don't get a second shot at it, although it's pretty easy to implant. Now, what is this going to mean for us moving forward as we're trying to choose these valves? The last quarter of 2016, we did more TAVRs than isolated aortic valves. Those lines are never going to cross again. They're going to do nothing but separate. The interesting thing is this is not a zero-sum game, because if it was, the red line surgery would be zero by now. It is falling. It's falling at our place, but what's happening is we're bringing in new people who never came in for treatment that are now getting treated. But that number is going to continue to increase. So the implications from this, and as we make our decisions, is that right now there's a line beyond which we don't go as far as risk. They're so high risk that I can get rid of the aortic stenosis, but I'll never make them better. They're futile patients. They're our cohort C patients. There's a risk that we don't go below without a trial, which is intermediate risk right now until we get to low risk trials. Now both those lines are really moving to the left. We just don't know how far they're going to go. And if low risk is non-inferior, which I predict it is, and we have durability, by 2021, everybody that's a candidate for a tissue valve will be a potential candidate for TAVR, but they're not all going to get TAVR. Because there's a difference between a 60-year-old tissue valve candidate and a 75-year-old tissue valve candidate, which is what will be our low-risk trial. There's a difference between somebody who has a big stalagmite of calcium coming down across the mitral valve that I can peel away as a surgeon very easily, and give them no leak, versus doing a TAVR valve in those people. It's very different doing a bicuspid valve. We do lots of bicuspid valves. Now, in somebody that's 60 years old, has a 4.2 centimeter aorta that you know is going to be back in 5 years and needs something done. So they're not going to disappear, but we're going to choose different valves for different implications. I think it's a really kind of an exciting time to be doing this. And if you had told me at the end of my career I'd do more valves in lead than in OR, I would have told you you're crazy. If you told me I was enjoying it, I thought you were crazier, but both are true. Thank you very much.